So ready? Do you want me to take over?
Yeah, ma'am. You can take over.
Thank you. A very good afternoon to each and every one of you here, respected faculties and delegates, for today's webinar on breast diseases saga. When we are talking about the rising heat all over India, we also need to talk about the rising hot problems about breast diseases. All of us are aware that the breast is primarily a gynecological organ, and we as obstetricians and gynecologists have to be very well aware about the various diseases of this particular problem, of this particular organ. And hence, to discuss this, we have none other than the Tamil Nadu OBGYN Society with us today, and we have our esteemed Dr. M.G. Hiremat sir as our chief guest for this particular webinar. I hand over the proceedings to Dr. Sneha Buyar Madam to kindly just enlighten us about the work of the Breast Committee and our current programs going on. Over to you, Sneha Buyar Ma'am.
A very good evening, respected Dr. P.K. Shah sir, who is not able to join for today's program, but we still remember him. Respected Dr. M.G. Hiremat sir, Dr. Sampath Kumari, Dr. Ramani Devi, Dr. Revati, all the esteemed guests and faculties here, and all the societies of Tamil Nadu Federation of FOGSI.
Anjalakshi madam, you have left. She is the
Madam, yes.
Anjalakshi madam.
Yes, so sorry, madam. Hello,
Okay,
madam Anjalakshi, a very warm welcome to all of you.
Yes.
And I am Dr. Sneha Buyar, Chairperson FOGSI Breast Committee, almost at the end of my tenure. And I would just like to share with you all in short that as Breast Committee, with all my advisors here, we are doing mainly focusing on three aspects, that is breastfeeding promotion, benign breast diseases, and awareness, screening, and early detection of breast cancer. Of course, timely and effective referral to the oncosurgeons and breast surgeons is included, of course, in that. So, as a committee, we have worked for last almost 4 years now, though the tenure was actually 3 years. We have done more than 700 programs, including virtual and physical, and we have discussed this issue in depth, right from adolescence to menopause. And we have organized CMEs, webinars, workshops for FOGSians to sensitize them on this issue. And we have published newsletters, updates, and ready reckoners for academic updates. We have trained the paramedical staffs, and at the same time, we have created awareness in the general public as far as the breast cancer is concerned, and organized lots of screening programs over last 3 years, more than 700 programs in total. So I thank you all the advisors for being with us in all our endeavors, and I would like to thank Tamil Nadu Federation, especially Madam Sampath Kumari and Madam Anjalakshi, Dr. Ramani Devi, once again Dr. Revati Janakiran, everybody. Thank you, all the presidents and secretaries of Tamil Nadu Federation, for being with us and having us here today for this occasion. Thank you so much once again. Over to you, Charu.
Thank you so much, Dr. Sneha. It is indeed a pleasure to be working with you on all these programs as your national coordinator for the last 2 years. We need to take the blessings of the Almighty before starting the webinar. And so we would like to virtually inaugurate this webinar in the presence of Dr. M.G. Hiremat sir, Dr. Anjalakshi ma'am, Dr. Revati Jankiram ma'am, Dr. Sampath Kumari, Dr. Ramani Devi ma'am, and all our esteemed faculty and delegates with this small prayer. Can we have the prayer, please, Mr. Reddy?
Kurutvam kalyanam arogyam dhana sampadah Shubham kurutvam kalyanam arogyam dhana sampadah Shatru buddhi vinashaya सम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Take us from darkness to light is what the lamp suggests all the while. And as we begin, before we begin our scientific program, though, we will be taking the blessings of all our esteemed chief guests and guests of honor today.
Maruti.
May I just introduce Dr. M.G. Hiremat, sir? Can we have the slide of M.G. Hiremat, sir, please? Hiremat, sir, is our esteemed chief guest today. He is our chief advisor of the breast committee because he himself has looked after the breast committee as a chairperson. He is also the past vice president FOGSI. Not only that, he is the former director, Karnataka Institute of Medical Sciences. He runs an IVF center. He is chief patron and founder secretary of the Karnataka OBGYN Society, the KASOGA. He has so many important things to his credit. He's extremely busy and still he has kindly consented to be with us today for this webinar. Dr. Hiremat, sir, we extend a warm welcome to you and we wish you to bless the webinar.
Namaste, namaste. Good evening, madam. Can you hear me?
Yes. Yes, sir. Please go ahead, sir.
Shall I proceed?
Yes, sir. Yes, sir.
Yeah. Good evening to everybody. In fact, I am in a very remote place. I am worried whether I am able to communicate to you or not. Still then I got through my mobile. I am very grateful to Charulata madam just reminding me 15 minutes back that program is likely to start immediately. Please join. It's a pleasure to be a part of breast committee because you know that the breast committee was not so active when I took as a chairperson. And we started so many workshops and others. Now today, what I am finding under the leadership of Sneha, the breast committee has become the top committee of the FOGSI, #1 committee of the FOGSI, doing so many academic programs. In fact, I was not able to cope up with all the programs. I could attend few of the programs, but all the programs were so excellent, so much knowledge. I think all those who are her committee members, including Charulata, they have done such a wonderful one. Please give them a very big hand because they have made this committee as the #1 committee of the year. And today, Galaxy of speakers are there and all our past presidents are there. Ramani Dev madam is there. And in fact, the way they are reaching to the state is also very nice because always we are thinking that things can be done under national. But now the committee is taking up to the Tamil Nadu, all the societies of Tamil Nadu. In fact, they had conducted the program with our Karnataka, 20 societies, and the whole programs were excellent. I wish a grand success to this program also because they have plans. Again, the title so beautifully given, Breast Diseases Saga. See, when we say Saga, so much of knowledge about breast diseases has been poured and so many textbooks have come. Earlier, absolutely no literature was available, and a day should reach where we are taking all the breast diseases to our side and woman should go to a surgeon. All problems of the breast and breast diseases must be solved by the gynecologist. That is the day I am dreaming. With such active people like Sneha, Charulata, the days are not far away that all breast problems are dealt by gynecologist. Thank you very much. I am waiting for your wonderful academic program. Thank you. Thank you once again.
Thank you so much, sir, for blessing the webinar and being here with us. We really look up to you and your amazing inputs that you always give us whenever you are with us. Thank you for being here for this.
Thank you, madam.
And now, thank you so much, sir. And now over to our guests of honor. We have none other than Dr. Anjalakshmi ma'am for this particular honor, who has kindly consented to be our guest of honor today. Can I have Madam CV, please? She is the founder president of TNFOG, and that is such an immense and huge job that she must have done along with Dr. Revati Jankiram, Dr. Sampath Kumari, Dr. Ramani Devi ma'am. Madam, we are indeed honored to have you here. You have been the past president of OGSSI. She has a PhD in pregnancy diabetology from the Tamil Nadu Dr. MGR University. Madam, it is so difficult to get a PhD. Otherwise, also after an MD and so many other degrees, you're getting a PhD is something that is really creditable. You've been the recipient of the Best Doctor Award from IMA. You're a retired professor OBG from Madras Medical Colleges, and you've presented numerous papers at national and international conferences. We are indeed to have you as our guest of honor today, madam. Over to you for your words of wisdom.
Thank you, Dr. Charlata. I'm very happy and good evening to everyone. Respected Chief Guest, Dr. P.K. Shah, Past President FOGSI, Dr. Hayarmat, Vice President FOGSI, Guest of Honor, Dr. Revati Janakiraman, the VIP is Dr. Ramani Devi, Past President of Vice President of FOGSI, Dr. Sneha, the Chairperson for the Breast Committee, and my Secretary, Dr. Sampath Kumari, who is the Vice President-elect, and Master of Ceremony, Dr. Charlata. Dear faculties and my dear delegates, it is a pleasure and honor for me to be the guest of honor. I am very happy that the Breast Committee has organized the Breast Disease Saga along with TNFOG. I congratulate Dr. Sneha for her efforts to empower the gynecologists on the breast disease. And it is so, I'm astonished that she has conducted more than 700 programs of this on breast diseases. The breast is OGYNs are the primary physician to women. So the complete breast examination should be done both in obstetrics and the gynec examination. The American Board of Obstetrician and Gynecologists has referred a separate role for the OGYNs in the diagnosis and treatment of breast disease, and it has indicated 1985 that it would require the knowledge about the breast diseases in its certification process. It also recommended that they should provide adequate information screening and also the symptoms, diagnostic studies like aspiration, bone, the fine needle aspiration technique, and appropriate follow-up and the treatment. So in this CME, we are going to have how to evaluate the breast lump by Dr. Sampath Kumari, an abnormal nipple discharge, and also an interesting panel on common breast problems and their management. I wish the CME a great success and my best wishes for this CME. I request all the delegates to enrich their knowledge on the breast disease and do counsel the women for the self-breast examination and also to report early. I thank the organizers for this wonderful opportunity. I thank once again with my best wishes. Jai Hind.
Thank you so much, Anjalakshmi ma'am. It is indeed a pleasure to get to know you, at least on a small level, and listen to your words today. Thank you so much.
Thank you.
Thank you. Can I have the next CV of Revati Jankiram ma'am, please? Our next guest of honor today is our past Vice President FOGSI from the South Zone, none other than Dr. Revati Jankiram madam. Madam has been the founder, secretary, and past president, Madurai OBGYN Society. She's the president, IMS Madurai chapter. She's the recipient of the FOGSI Dr. Duru Shah Community Service Award, and also has received a Lifetime Achievement Award from IMA Madurai. Madam, it is indeed our proud privilege to have you here today as our guest of honor. We would like to hear from you.
Thank you, Charlata, for your kind words. Good evening, dear friends. Thank you very much for your kind invite to be guest of honor in this interesting webinar on breast lesions. Actually, though we included breast as part of the gynecologists and not as surgeons, and in spite of teaching our students, both UGs and PGs, that breast examination must be a part. It is very important, both not only in gynec but also in obstetrics. In general practice, many times they just do not take it as a routine. and they examine only at the time of any complaint with the breast problems. But that should change. And in our day-to-day practice, we get a lot of patients coming with a discharge, lump, and also mastalgia. Mastalgia is an area, gray area, which is treated many times with empirical management. And the topics that have been chosen today, like management of lump and discharge in the breast, and also panel discussion, I'm sure definitely it is going to be of much use for all the practitioners and all the delegates who are attending it. And during my vice presidency of FOGSI, Dr. Kavita was chairperson of breast committee, and breast committee was under me, and Sneha was also there. And what a lot of work that was done by breast committee, and they received the award also. And I'm very happy to see Sneha also doing even much better work, and really congratulate Sneha for your wonderful job during your tenure. Wish you all the best, and I wish this webinar a grand success. Thank you very much.
Thank you so much, madam.
Thank you. Thank you very much, Revati ma'am. Thank you for your kind words. With that, we conclude that the inauguration ceremony is over, and we move ahead to our academic session for the evening. I would like to welcome, I really sincerely thank our chief guest and our guests of honor for sparing their valuable time for being with us. Thank you so much for blessing the webinar. And now over to the academic session, for which I would like to invite our chairpersons, Dr. Lakshmi Prabha ma'am and Vanitha Rukmani madam. May I have the CV of Lakshmi Prabha madam, please? Mr. Reddy?
Just a moment, just a moment.
Yes, thank you so much. Dr. Lakshmi Prabha madam is a DGO, DNB, FICOG and a consultant OB/GYN at Maruti Hospital and Rana Hospital, Tiruchirappalli. She has won the C. Subramaniam Award for Best Outgoing Student in Clinical Surgery in 1997 and has been on the executive committee of TRIOGS for the past 13 years and currently is the joint secretary in TRIOGS. Can I have the next CV of Dr. Vanitha Rukmani, please?
Charu, she is a secretary, not joint secretary.
Oh, I'm sorry. I just read
No. Maybe old slide. She is a secretary.
Yes. Madam is the secretary. Dr. Vanitha Rukmani madam, also a woman of high esteem and high intellectual with an MBBS, DGO and MSOG from Theni Medical College. She's the senior assistant professor at Theni Medical College and a consultant obstetrician and gynecologist. I'm sorry, I cannot pronounce the name properly, maybe, Natathi Nadar Hospital, Theni. She's the secretary of the Theni OB/GYN Society currently, has been a speaker and organizing secretary for a number of FOGSI meetings in Theni. She has special interest in high-risk obstetrics and infertility. Thank you so much, Dr. Lakshmi Prabha and Dr. Vanitha, for consenting to be our chairpersons, and over to you for the next proceedings. Lakshmi Prabha ma'am, can you unmute yourself?
Charu, I will share my screen.
She has unmuted, but then I think problem with her device. Can you just try without earphones? Yeah, your volume of the device is low.
Can you hear me now?
Little, but you have to increase the volume, or maybe you remove the earphones.
Good evening to one and all. It's indeed a
great still some more. We can't hear you, Dr. Lakshmi Prabha.
It's indeed a pleasure and pride to be a part of this breast disease saga organized by FOGSI and Female Breast Committee FOGSI. We move on to the first topic of today, evaluation of.
No problem, Sneha.
Madam?
Dr. Sampath Kumari, Vice President-elect. That's all. We will start.
Founder Secretary TNFOG.
Yes, Founder Secretary TNFOG, our Vice President, Dr. Revati Madam. So I'll share my screen.
Yes, yes.
Winner of so many FOGSI awards, madam.
Ama Madam. Ramani Madam. Yes. Lakshmi Prabha, are you there? Shall I start?
Yes, madam. We welcome you to start the program, please.
No problem. Thank you, Dr. Lakshmi and Dr. Vanita. Today, and first of all, I thank Dr. Sneha and Dr. Charlata for the wonderful webinar organized by Breast Committee, and thanks to our TNFOG President, Dr. Anjalakshmi Madam, and Vice President, Dr. Revati Madam, and active member of TNFOG, Dr. Ramani Madam. So, and all our members, all our society, we have 18 societies. We are doing monthly 2 CMEs, 1 PG program, and the public forum. And next year, our aim is to reduce the maternal mortality. So, this is TNFOG. With this, I will proceed to my topic. Breast lump, how we are supposed to approach. See, if the breast lump is, first our aim is to exclude malignancy and then provide diagnosis. If you want to exclude malignancy, means we should have the diagnosis and explanation, whether it is benign or malignant. If it is a malignancy, means definitely we need the tissue biopsy, that is pathology biopsy. So the diagnosis explanation is very, very important. And before any lump to be recognized, all lumps to be benign before going for observation. Now, if at all you see a lump of about 2 into 2 to 3 centimeters, you can go for observation, but it should be proved that it is a benign condition and it is not a malignant condition. So for any lump, if it is not a malignancy, you should prove this has to be a benign and go for an observation. So what are all the history? If a woman comes and tells, I have the lump, or she will tell us a mass. So we have to see whether the mass is hard or irregular. If it is hard and irregular, what is the growing size? Whether it was started to be 2 centimeters and now it has attained the size of 8 centimeters. Fast growing means we have to think of malignant changes. And the skin over the breast and the nipple changes. If the nipple is everted and if there is any discharge present, I think the next talk is about the nipple discharge. The bloody discharge, any discharge is present, we have to think of malignancy. Whether the discharge is simple or more frequent, the frequency is very, very important. So the history, if the patient gives the history of lump, we have to palpate and see whether it is hard or irregular and whether it was small to start with and what is the skin changes over that and the nipple changes, any discharge from the nipple. So again, this is the history pertaining to the breast. And with this, we have to know what is her obstetric history, whether she is married or whether she is unmarried, how many children she has delivered, whether she has fed the baby, how long she fed the baby, or she has never lactated the baby. These are all the history we need, and the menstrual history. When she attained menarche, whether the bleeding was regular, whether she had any breast tenderness before menstruations, or whether the lump was present during menstruations. This history of obstetrics and menstrual is needed, and the family history, whether her mother or sister, anyone has had the similar complaint of lump in the breast, any mastectomy done, whether the pathology report has proved as malignancy. So these are all the history we have to elicit. First, you concerned about the breast, and then you have to think about the obstetric history and the menstrual history. So if they tell that my sister or mother had a malignancy of the CA breast, so in that cases, we have to ask whether how it was started and what was the biopsy report. To tell us malignancy, biopsy is very, very important. Then comes the systemic assessment. So now we have examined the breast and obstetric history, elicited, menstrual history is also elicited, and the family history. So all things we have finished. Then we have to go with the other systems, whether she is suffering from any neurological problem, Parkinson's disease or any other disease, and cardiac problem, whether MS, MR, and any other vascular disease, whether any bleeding tendency. So other systemic assessment is also important before we come to the conclusion that it is a benign or malignant. So the same thing, when a girl, that is women, completed the family, in the premenopause age comes with a lump in the breast means, we have to ask about the last menstrual period and the regularity of the menstrual cycle, whether this mass is present before menstruations or during menstruations or after menstruation, or any history of oral contraceptive has been used, and any hormonal therapy has been taken. Previously, any lump has been removed from the breast. Like that, the all history is very, very important. If there is a post-menopause, after menopause, most of the time after menopause, they will come only in the advanced stage with the nipple retracted and any ulcerations and use of any hormone therapy, whether they are taking any HRT for post-menopausal or previously they have been diagnosed as malignancy in the breast and any hormone therapy they are taking. So these are all the things with the history, whether pre-menopause or perimenopause is important. Then the systemic approach, as I told earlier, neurologic, pulmonary, cardiac, musculoskeletal, hematologic, pain in the localized pain or pain radiating to the shoulder or any other pain, cough is present, whether lungs are involved. So all system has to be elicited. So for a lump in the breast, first they examine the breast and then obstetric history, menstrual history, then the systemic approach. How are we going to advise the patients for the self-examination? These are all the methods. They can be in the supine position or in the sitting position with the hands tightly controlled over the hip. So this is the exposure from A step and examine supine sitting. We should advise the patient to do it by herself itself. We should teach her how to examine the lump and it should be how it has to be palpated. I will show in the next slide. And this has to be done every month on the same day. That will be the best. So self-exam, how we are going to advise her to do the self-exam? That is after 30 years itself we can start. First, they have to see both the breasts are equal or one breast is small and the other breast is big, whether any prominent lump is seen, whether any ulceration is seen. Then put your hands on your hips, pull your elbows forwards. So they have to put their hands on the hips such that the tensity will be there. And then the three fingers, with the softness, they have to examine the finger. Right hand breast with the left fingers and the left hand breast, left side breast with the right fingers. So when there is a lump is palpable, the surrounding areas also has to be examined. Whether the lump, with that we can identify whether it is a smaller mass or whether it is a bigger lump. So this test has to be done once a month only. You should not ask the patient to do it daily. Some patient will be very scared and they will be doing daily. So preferably it has to be done only once a month. That too before the menstruation. Before menstruation, if they are dying, means it will be comfortable. So self-examinations in our OP, we should have a picture of poster of the self-examinations of the breast. Then whether we have, as I told, both the side is breast is same, or whether there is a difference in shape and size, whether the nipple is normal or nipple is retracted in one side, nipple is elevated in other side, that has to be examined. So everything has to be documented when we examine. Then the skin, with the skin, I told you already, skin and the ulceration has to be seen. In the skin, whether retraction is present, tethering, edema, inflammation, ulceration, any nodules is present, everything has an importance. So you should have a checklist. If a patient comes with a breast lump, means with the checklist, you should continuously tick both the sides, same size. One side and a mass is present, the size of the mass, the nipple is inverted, and the skin is retracted, then discharge is present. Everything has to be mentioned, and then the character of the lump. Whether the lump is soft or it is hard, whether it is movable, whether it is fixed. You cannot, if when you touch the lump, whether it is tenderness is present, and then go to the lymph nodes. In the axillary lymph nodes, supraclavicular nodes, so whatever nodes it is present, that has to be mentioned. So if the lump is present and the lymphadenopathy is also present, then we have to, depending on the FNACA report or pathology report, we have to state. So this is the self-examination under the lump of the breast. So breast lump means first physical examinations. No abnormality means tell the patient, now you are only 2 centimeters, nothing to worry, it will go subside. Or if it is needed, you go whatever advice you want, any surgery, that has to be advised. If the thickening is present, again, you have that skin thickening alone is present, when sometimes it may be due to any inflammation. So ask her to come after 2 months or 3 months. If you think the whatever the lump you see, it looks like a imaging. That is, if a 32-year-old girl, woman comes with the tells that a 3 into 3 centimeter lump is present, means first we have to think of benign only. If there is a nipple discharge and any bloody discharge and skin retracted, nipple is everted, only we suspect of malignancy. So in this clinically benign cases, you can go for imaging. So MRI normally we don't do before 35 years. So ultrasound is now the good sonologist can tell whatever it is needed. So sonology is very, very important. Mammography, we will normally we don't do before 30 years. If you have any suspicions over the scan, then after 35 years, completed family, we can go for the mammography. Always it is done in 2 views and it is bilateral, and it is with this mammography, we can know whether the lump is benign or malignant. There will be the reports of BIRADS 1, 2, 3, 4, 5. 1 and 2 is almost normal, 3 and 4 will be the almost depending on the malignancy. So what are all the indications where we should do the mammogram? As I told, age about 30 years, and if there is any palpable mass and thickening of the skin, and inflammatory breast changes and skin changes is present, and any suspiciable nodes, axillary lymph nodes are present, then we have to go for the mammography. Similarly, even for the male, if they have the gynecomastia and any mass is present, there also we can go for the mammography. Though screening is normally before 30, we don't go for the mammography as a screening procedure. After 35 years, and if there is a high risk cases and the family history of CA breast positive means, then you can go for a mammography as a screening. So what are all the dangerous signs? Shape, irregular nodular, margin speculated, indexed micronodular, and calcifications if it is seen with this clustered, pleomorphic. These are all the good sonologists will read this pictures, whatever is needed, and the architectural distortion. If the distortion is present means we can be very, very suspicious that it may be a case of malignancy. So this is the way the picture after the mammography, they will report. BIRAD 0 to 6. So 0 means no further assessment. If 1 and 2 means normally we can advise her to go for a mammogram once in 2 years, definitely. 1 is normal, 2 is benign. So if it is after 2 years, if it is goes to the 3 stage or 4 stage, then we can be suspicious. 3 is probably benign, 4 is suspicious. So every 2 years they have to do the mammogram. Always if it is in the BIRADS 2, nothing is nothing to worry. And if it changes to 3 or 4, then it comes the suspicious. Then we have to go for the tissue biopsy. BIRADS 5 means a strong suspicious. Now the woman with the 35 years with the lump, she is coming and she has completed the family. Now you are taking the mammogram, no family history also. But the BIRADS comes as 4 or 5 means definitely it is a suspicious of malignancy. That by clinical examination itself, we will find it out that they may be a case of malignancy. Then they have to go for a biopsy. So for what are all the factors that is affecting sensitivity, age, hormone therapy, factors, silent factors, these are all the factors affecting the sensitivity. So imaging is very important and accurate tool can characterize. This is the ultrasound. Normally we don't advise mammography before 30 years, but ultrasound imaging can be done for everyone, anyone. Even nowadays, the adolescent girls are coming with a lump and the mass. In that case, if it is a fibroadenoma also, you can go for a breast ultrasound. So these are all the procedures. So whenever they are reporting, the sonologist should be meticulous and skillful, and they should be able to perform even the biopsy. If you advise that if it needs the biopsy means, they should be capable of doing the biopsy and the BIRADS reporting. That is very, very essential. So why we are doing this means to characterize the mass, whether it is benign or malignant, and to suspicious with the ultrasound. If it is suspicious, we go for a MRI. In the MRI, if it is after a BIRADS 2 means, then we have to go for the biopsy. So with the ultrasound, what are all the benign features is hyperechoic texture, elliptical shape, gently lobulated shape, complete thin capsule. These are all the benign features. These are all the dangerous features with the ultrasound, which we can suspect as a malignancy. Speculations, angular margins, acoustic shadowing, and hypoechoic microlobulations. These are all the duct extension. Pattern itself, architecture itself will be completely changed. Branching pattern, calcifications. In these situations, we should be very alert and think of malignancy. And to confirm that, you can go for the MRI. MRI is the next stage where we can confirm whether it is benign or malignancy. So now we have the picture of MRI and we have the suspicions of malignancy. Just like that, you cannot tell the patients that you are having the malignancy. You may be having malignancy, but it needs the tissue biopsy. So you have to go for biopsy to confirm that she is having the CA breast. What are all the types of biopsy? It can be an FNAC biopsy, fine needle aspiration biopsy, and it can be a core biopsy, that is the true cut biopsy, vacuum assisted biopsy, incisional and excisional biopsy. Incisional biopsy, most of the time we don't prefer. This is the FNAC. This is easily performed. It can be readily available and there is no need for even anesthesia. So less pain, ecchymosis and hematoma. So this is FNAC can be easily done. What is the disadvantages? Since we are going with this under ultrasound guidance only we are doing, still the material may not be sufficient and the invasive character cannot be commented. So these are all the disadvantages of the FNAC. But to confirm, we have to go for the FNAC. This core biopsy is another next stage. So if you are not suspicious with FNA means core biopsy, in the core biopsy, you can have more tissues. Needle will be thin, FNAC will be a thin needle. Here will be a heavier thick, bore will be very thick. And you can have many materials. Materials will be more. But only thing, it will be discomfort and the patient will have pain. So these are all the core biopsy. This core biopsy has to be done under local anesthesia. That is 2 to 3 millimeter incision will be made and 14 to 18 gauge needle is used. And the procedure, the tissues has to be taken. It may take 10 minutes. FNA is only 5 minutes procedure, means core biopsy can go for a 10 minutes procedures. Where you want to confirm the diagnosis, you can go with this core biopsy. This is the vacuum aspirated biopsy, where we are creating the vacuum and then the biopsy is taken. Here the biopsy tissues will be, chunk tissues will be present. So this is more expensive. I have never done this vacuum assisted biopsy. Whoever has done or experienced with vacuum, I think Sneha will be a better person to explain about the vacuum assisted biopsy. I have never done. I don't know about others. So this we have a more tissue and it is expensive. Then comes the incision biopsy. If you don't have any patient is not willing and if you are not comfortable with the FNAC and core biopsy, you think this biopsy report will not be sufficient. We need only the lump pool for the pathology to be confirmed. Then you go with the excision biopsy. Incision biopsy, most of the time it is not done. Excision biopsy is a small incision is made and as far as possible, almost most of the lump or chunk of a lump will be taken. That is the excision biopsy. The patient will be, we can have confirmatory findings. With this excision biopsy, we can tell whether she is having a ductal carcinoma, lobular carcinoma, whatever it is. Full lump has to be taken for the excision biopsy. Small incision, the whole lump will be taken and the biopsy of malignancy will be confirmed. So these are all the biopsy, FNAC, core biopsy, vacuum assisted, excisional biopsy. Incisional biopsy we are not doing. So before this, we have to tell the patient, see, your report can come as malignancy and you may have to go for future mastectomy. If at all needed, you can go even for a chemotherapy. The drugs will be given. With the drugs, there may be some side effects like loss of hair, hemoglobin reduced, like that. Everything has to be counted. Though the patient comes with the lump, comes as a lump. If you suspect a malignancy, you can tell her it may be a malignancy or it may be a benign, but 90% it will be a malignancy. But these are all the complications that can happen. So this is the way you should counsel the patient. Then this is the triple test. What is triple test? It includes the clinical findings and it includes the radiological finding and the pathology. So finally, with the multidisciplinary, we can confirm that she is a case of malignancy. So this excision biopsy is also important. So finally, this is the mass. As I told earlier, the first, if the patient comes with the lump, with the ultrasound and the mammography, and you can see what is whether benign or malignant, and then you take the biopsy, core biopsy or excisional biopsy, and confirm the malignancy, and then refer the patients for treatment. So conclusions. First, you should counsel all the women after 30 years to do the self-examination. There are some studies which tell that even the self-examinations may not be helpful. but you can definitely pick out a mass with the self-examination. So you should teach the patient how the self-examination should be done, and it should be done only monthly once. Palpable masses should never be missed, and imaging should be performed before biopsy. And in younger ladies, ultrasound is preferred rather than mammography. The MRI is the test to confirm. After the ultrasound, you can go for MRI. But if she is over 35 years and she comes with a lump, means there is no necessity that you have to go for a ultrasound only. You can go straight with the MRI. Triple test is the standard, which tells about the benign and malignancy. And a small cyst, if it is present, under the ultrasound guidance, it can be aspirated. And the cytology is very, very important for everything. Pregnant and young patients pose a diagnostic challenge because of the density. So you have to wait in the delivery. After that, you can identify the biopsy. So ultrasound is non-invasive, and even for adolescents, it can be done. Thank you. Once again, I thank Dr. Sneha and the organizer for giving me this opportunity. I'll stop share. Thank you. Vanita.
Yes, ma'am. Good evening, madam. Thank you, organizers, Dr. Sneha ma'am, Dr. Ramani ma'am, Dr. Anjalakshmi ma'am, for giving me this opportunity. Ma'am, you have covered in detail, madam, about the importance of elaborate history taking and the physical examination of self-breast examination and various imaging techniques, ma'am. And
thank you, Vanita. Sneha is the master of what to tell all about mass in the breast.
Yes, ma'am.
Sneha, you should come to our FOGSI bunch. We will invite you.
Thank you so much, madam, for your invitation. I'll be there positively.
Thank you so much for that exhaustive talk, Sampath Kumari, madam. It was indeed a pleasure listening to you. And I think that, we have covered all the basics that are necessary for evaluation of breast lump. So if the chairpersons wish to interact a little further with Sampath, madam. Dr. Lakshmi, madam, and Dr. Vanitha, madam.
Yes, Dr. Vanitha has shared her remarks.
Yes,
Vanitha is from Theni. Lakshmi is from Kochi.
Sampath, I have one question for you.
Yes, madam.
See, we know BIRATs up to 5. Where from you got this BIRAT 6?
That's from I got this 6, Sneha. No, it is that from the Google I got it. There are some classifications with this. But in our place, we have to see up to 5 only. But 6, I got it from one literature I saw, madam. So I thought we will put it.
Okay, that's a new.
0 also normally we don't have. BIRAT 0 normal 1, 2, 3. But 0 and 6 I saw.
Yes, because
so I thought we will project. That's all.
Madam,
give BIRAT 6, madam.
Yes, madam,
we give the reference, but
Deepa?
Many centers give 6 as reference, 0 to 6.
Madam, good evening, madam. Dr. Vaishnavi here.
Yes,
Williams Gynecology mentions BIRAT 6, madam.
Latest, I will put the reference, madam. Before this, I will take the reference. Vaishnavi, that you can take a photo shot of Williams if you have and put in the chat box. Otherwise, I'll send to Ramani, madam, later.
Sure, madam.
Thank you so much for that interesting discussion. And with that, we move ahead to our next talk. And for that, I would like to invite Dr. Chandra madam and Dr. Preeti madam as our esteemed chairpersons for the same. Thank you so much for consenting to chair this particular session, madam. Can I have the CV of Chandra madam, please? Mr. Reddy?
Charu, Kartika Prabhu is there.
Yeah, she's there.
She's going to be the speaker, so the chairpersons will introduce madam.
I saw her.
Kartika, irkiya?
Yes, madam, I'm there.
Yes, okay. Okay,
yes. Welcome, Dr. Kartika.
Dr. Reddy, Mr. Reddy, can I have the CVs, please?
Taru, if you have, you can share from your end.
I don't have. I will have to just read out.
You can.
What is happening?
Chandra and another one, Huma.
And Preeti.
Preeti. Dr. Chandra is the founder, president of Namakal Society. Chandra is the big boss of Namakal Society. And she was the first one to start the IVF center in Namakal.
Oh my.
Welcome, Chandra madam.
Before Charu introduces the chairperson, I would just say this BIRAD 6, no? 0 to 6.
Yeah.
Total 7 categories. This is by the American Society of Radiology.
The standard textbook.
Yes, it's a biopsy proven breast malignancy. Thank you.
Okay. Thank you so much, Sneha, for that. I'm sorry, I don't know why Mr. Reddy is not sharing, but thank you.
I'm sorry. I was on a phone call. I'm sorry.
Hey, and you can proceed with
no problem. I had told her. Then Preeti, are you there, Preeti?
OBGYN Society, I think. So Dr. Preeti and Dr. Chandra, over to you all for conducting the
Preeti is the secretary of Vellore Society. I am not able to see her.
Yeah, she's there.
She's here.
She is from Vellore CMC Medical College.
Fantastic. Welcome, Dr. Preeti. And over to both of you as chairpersons for the next session.
Yeah.
So ready? Can we have the CV of Dr. Karthika, madam?
Yes, ma'am.
Yes, okay. Yeah, I'm happy to be part of this webinar and the session on abnormal nipple discharge. And I thank the organizers, Dr. Sneha, Dr. Charlata, and our own TNFOG President Dr. Anjalakshmi Madam, the Sampath Kumari, and Dr. Ramani Devi for this opportunity. And it is my privilege to introduce Dr. Karthika. She is the professor of SRM Medical College Hospital and Research Center, Poteri, and she did her UG, PG, and MMC and PG in JIPMER. She is an undergraduate and postgraduate teacher. Her special interests are high-risk pregnancy and gynec endoscopy. She has got many awards: Dr. A.V. Umachigui Memorial Gold Medal, Dr. Asha Bakshi Award in the annual conference of AICC RCOG 2016, and she has got the prize in paper presentation FOGSI South Zone 2011, DIPSI 2013, and she has got gold medal Research Day SRM 2020, and she received Dr. A.L. Mudalia Traveling Fellowship, and she has 60 national and international publications, and she is a faculty in many national and regional conferences. You're welcome, Dr. Karthika. The is yours, and you can start your lecture on abnormal nipple discharge.
Thank you, ma'am, for the introduction. First of all, I would like to thank the entire organizing team of FOGSI Breast Committee and TNFOG for giving me an opportunity to be a part of this webinar. I'll share my screen. My screen is visible, ma'am.
Yeah. Karthika, slide show pade.
Yeah, just click on the slideshow.
No, actually, it's keeping on moving.
Hello, Richard, have you completed?
Just click on one of the slides. Just click on the slides, and then you click on the slideshow.
The slideshow from the beginning.
Animations kaduthe irukku paru Karthika. Yes.
Yes, perfect.
Today I will be talking about evaluation of abnormal nipple discharge. So at the end, we will be able to know what are all the important features in abnormal nipple discharge, know the causes for abnormal nipple discharge, and the various diagnostic tests which is appropriate for identifying the causes for abnormal nipple discharge. So the most common breast problems with which patients present to the obstetrician gynecologist is breast pain, nipple discharge, and a palpable breast mass. So during the reproductive years, nearly up to 80% of women will have some episode of nipple discharge, but most of the nipple discharge is of benign origin. Galacturia occurs in approximately 20 to 50% of the women, and 7 to 15% of nipple discharge may be due to breast carcinoma. It has been reported that 10 to 15% of women with benign breast disease and 2.5 to 3% with breast cancer, they may have nipple discharge. So the main goal in evaluation is to differentiate patients with benign nipple discharge from those who have an underlying pathological problem like papilloma or cancer. And the main goal is also for managing such patients with pathological nipple discharge. So nipple discharge, whether it is physiological or pathological, can be elicited from the history and physical examination. There are various types of nipple discharge. It can be milky, it can be multicolored and sticky, purulent, clear and watery, yellow or serous, pink or serosanguinous, bloody or bloody discharge. So based on the color of the discharge, we can identify some of the causes. So if it is a milky discharge, it may be probably because of hyperprolactin use. Multiple ducts. A serous or a serosanguinous discharge will be present in intraductal papilloma or intraductal cancer. Usually this type of discharge will be unilateral, mostly involving one duct. Bloody discharge is also a feature of intraductal papilloma, intraductal cancer, inflammation or trauma, and it also will be usually unilateral, involving one or two ducts. A green color discharge is a feature of hydrocystic disease, and it is bilateral, involving multiple ducts. So normally milk production occurs during pregnancy and lactation, and it may persist up to 1 year postpartum or after cessation of breastfeeding. Milky nipple discharge also occurs if it occurs in a female without recent history of pregnancy or lactation, is called as galacturia. It is usually bilateral, involving multiple ducts because of inappropriate increase in prolactin. So the evaluation of galacturia is different from the other abnormal nipple discharge. This is because galacturia is not a symptom of breast cancer or a primary. So the cause may be physiological or it may be pathological. So the physiological cause.
Kartika ma'am.
Dr. Kartika, your internet is unstable.
Lesions like prolactinoma, empty cellular syndrome, lymphocytic hypophysitis, or it may be following systemic disorders like hypothyroidism, chronic renal failure, cirrhosis, sometimes occasionally like chest wall lesions and chest injuries. Yes, ma'am, I'll check. I'm audible now?
Ma'am, Kartika ma'am, video off பண்ணுங்க, it will be okay then. The video off பண்ணுங்க, that will be fine.
Yeah, that will be better.
Or it may be hormone induced. So that is drug induced. So most of the antidepressants and antipsychotic drugs can cause galacturia. Antihypertensives, which we used to use, like methyl-dopa, can also. Am I audible now?
Yeah.
There is interruption.
Dr. Kartika, but there is interruption in between.
Now am I audible?
Yes, we can hear you.
Okay, so among the drugs, antidepressants, antipsychotics, and antihypertensives like methyl-dopa can cause galacturia. Even OC pills and DMPA injections can cause galacturia. So the diagnostic test in galacturia will be, main thing is measurement of serum prolactin level, thyroid function test, and renal function test. If the serum prolactin is more than 100 nanogram per ml, MRI may be required. And the treatment options will be dopamine agonist, cabergoline, or bromocriptine can be used, and surgery and radiotherapy depending upon the tumor size and the associated symptoms. Sometimes physiological discharge can occur following only on compression. So it will not be spontaneous. Usually it will be bilateral with multiple duct involvement. So a careful history will usually help us to identify a physiological discharge. So the management for physiological discharges, it resolves when the nipple is left alone. But especially if the woman is more than 40 years, you have to do a thorough breast examination with mammography. So in the pathological nipple discharge will be usually spontaneous. It will not be, it will not come with compression. It will be spontaneous, and it usually involves a single duct, and it will be unilateral. The type of discharge will be either clear, serous, or bloody secretion. If it is a green or a milky secretion, it's most probably not due to breast pathology. It may be associated with if it is associated with mass, again, it indicates there is a pathological nipple discharge. So among the pathological causes, so the most common causes will be benign conditions like intraductal papilloma, duct ectasia, and fibrocystic changes and mastitis. The malignant causes may be intraductal carcinoma and disease of the nipple. So again, the first diagnostic workup in females with nipple discharges, a detailed clinical history and physical examination. So clinical history, that is the type of discharge, whether it is bilateral and whether it is spontaneous, will help us give a clue regarding the pathological nature. And history of ipsilateral cancer or family history of malignancy and age over 50 years with breast mass will be more towards pathological nipple discharge. Again, next comes the examination. Examination completes breast evaluation with inspection and palpation is very important, which Madam has already discussed in detail, with the focused inspection of the nipple area with a magnifying lamp. So you have to see how many the discharge is coming from where. So whether it involves a single duct or it is a multiple duct, and we also should look for any mass. So the nipple also, if it is a malignancy, you may have an inverted nipple, retracted nipple, or deviation of nipple towards one side. All these features will suggest more towards malignancy. So as I have already mentioned, you have to see the color of the discharge, the number of ducts involved, the frequency of discharge, whether it is persistent or intermittent, whether it is unilateral or bilateral. So the most common conventional imaging technique which is used to investigate nipple discharge is mammography. It is generally advised for women more than 40 years because in a younger patient, because of the dense breast tissue, we may miss small lesions. For patients with between age 30 to 40 years who are all high risk for malignancy, you may have to do mammography to exclude the presence of microcalcification. And in women less than 30 years with ultrasound showing suspicious lesion, we may have to go for mammography. So mammography has low sensitivity and limited accuracy in the detection of retroareolar lesions, so which are small, intraductal, and without calcifications. So mammographic findings may range from microcalcification, we may see a mass, focal density asymmetry, architectural distortion, or ductal ectasia. So microcalcification with branching or linear pattern, variable density, or distributed in a segmental way are all highly suspicious of malignancy. So in the picture, the ones towards the right are all features of malignancy, whereas the picture on the left, which shows round or rod-like calcification, suggests a benign disease. So ultrasound offers a better performance than mammography for detecting intraductal lesions. So ductal ectasia, which is defined as a duct caliber more than 3 mm, is one of the most common findings seen on ultrasound. So it appears like a dilated retroareolar duct which contains anechoic fluid or hypoechoic debris. So intraductal papilloma appears like a nodule with a central vascular pedicle on color Doppler. So the irregular duct margins with wall thickening or a hypoechoic intraductal mass with acoustic shadowing are features of malignancy. So the picture on the right is a duct with irregular duct. That is, the margins are irregular. There is irregular widening of the duct. So nipple discharge cytology can sometimes pick up malignancy, but American College of Radiology has told that it may not be helpful fully in differentiating benign from malignant lesions because of high false negative findings. So it is, and further it does not help in localizing the tumor. But recent techniques like duct lavage and duct endoscopy, where you visualize the duct, that is called ductoscopy, may help you with identifying the localizing the lesion. So ductoscopy provides a direct visualization of the intraductal lesions and allows for directed excision and facilitating targeted surgery. The benefit is it avoids extensive surgical resection with healthy breast tissue conservation. So galactography is one technique where you push a dye inside contrast media and take a mammogram. So it helps us to visualize and localize the intraductal lesion, but again, it does not help us to differentiate between benign and malignant pathology. So MRI is an effective alternative to galactography. So it has an overall sensitivity of breast cancer for breast cancer is 90 to 99%. Contrast enhanced MRI allows imaging of both breasts with a good visualization of the retroareolar regions. It also helps to identify lesions which are located in the deepest areas of the breast. So it has a role in patients with negative mammography and ultrasound where we strongly suspect malignancy. So MRI provides an excellent visualization of the dilated ducts and their content, and it outlines their pathology in good detail, adding physiological information to the morphological detail provided by mammography and ultrasound. And if you see a suspicious lesion in MRI, then we can go for an image-guided needle biopsy. So surgery also may sometimes help in cases of intraductal lesions. So terminal duct excision is both diagnostic and therapeutic for benign conditions. So either you can go for a total subareolar duct excision or a selective duct excision, which is called as microductectomy of the single duct. The benefit of microductectomy is the preservation of the remaining tissue, and it is a better option for young females. Whereas major duct excision is preferred because we can pick up even occult cancers can be picked up to a greater extent. To summarize, so first we have to see the color of the discharge, whether it is spontaneous or it is provoked by stimulation, whether it is a single or multiple duct. So if it is a blood discharge, serous or a serosanguinous, spontaneous discharge, which is usually unilateral involving a single duct, most likely it is a pathological one. So there you have to go for mammography and ultrasound. And if we see abnormal area, you have to take a biopsy. So if you have a negative finding, still we are suspicious, you can go for a MRI. And depending upon the, suppose a lesion you are able to pick up, you can go for a surgical excision. So if there is a physiological discharge, again, if the patient is more than 40 years, you have to do a mammography. If she is a less than 40 years and she is low risk, we can just observe her, but we have to rule out other systemic causes for nipple discharge, like raised prolactin levels and elevated TSH, which can be managed medically. So most nipple discharges may be because of benign condition, but always we should keep in mind we have to rule out malignancy. So evaluation and diagnosis of nipple discharge is important for early detection of carcinoma. So we have some simple non-invasive or minimal invasive techniques are there for evaluation and managing this. So nipple discharge which occurs on squeezing is common. So in those cases, we need not overburden with investigations. Thank you all for your patience.
Thank you, Dr. Kartika, for your excellent presentation. The entire thing about the abnormal nipple discharge. So we should not leave any discharge as physiological, and it needs to be completely evaluated. That's what we learned from your lecture. And Dr. Preeti, anything to say?
Thank you, Dr. Karthika. That was a very clear presentation. You emphasized on the importance of history taking and basic clinical examination that will help us to identify and also differentiate between a benign and a malignant. And you also explained in simple terms what are the abnormal findings in the investigations and when to start investigating. That was a very clear explanation. Thank you.
Thank you, Dr. Karthika, for that excellent, exhaustive talk. And thank you, Dr. Preeti and Chandra ma'am, for chairing this session. Wonderful comments as well. If any questions, we can have it, if at all, chairpersons. Dr. Charu has just gone for some emergency, so I will continue this session ahead. So if at all any queries, please let us know.
Yeah, she has made it clear.
Yes, she has made it very
Thank
clear.
you once again, ma'am, for giving me an opportunity here.
Thank you so much, Dr. Karthika. So I think we should move on. I would invite Dr. Ramani madam for the panel discussion. Charu, I can see Dr. Charu. You can go ahead with the panel discussion. Yes.
Absolutely. And so now for the much awaited panel discussion that we are going to conduct will be on management of routinely occurring breast problems. I think we as gynecologists have to deal with a number of small problems, whether it is a little bit of pain, whether it is a little bit of heaviness, changes in the sizes of the breast, and all this has to be dealt with very efficiently by us. Yes, Mr. Reddy, I would like to have the CV of Ramani Devi madam. I must sincerely thank Ramani madam for all the help that she gave me to make sure that we could conduct this webinar today. Sampath Kumari ma'am was instrumental and Ramani Devi was a big support. Thank you so much, both of you. Ramani madam has been the chairperson of the Endometriosis Committee of FOGSI 2014 to 2016. She's a member of the Consensus for Endometriosis in Asia Pacific region. Madam, it is indeed always a little frightening to be in your panel of endometriosis because you are so well versed with this particular disease and you keep enlightening us upon it time and again. She has been the investigator in the POISE trial published in Lancet, editor of FOGSI GCPR on endometriosis, and she has so many awards and accolades to her credit. She belongs to a doctor family, extremely intelligent family, as we were discussing in the AICOG the other day. She has been awarded the APJ Abdul Kalam Award, and CL Javeri Symposium has been conducted by her for the year 2019. Best Woman Doctor Award by Tamil Nadu State IMA 2019, and Best IMA National Secretary Award and Best Secretary of Tamil Nadu State. She has, of course, been our esteemed Vice President of FOGSI 2020. She is on the International Advisory Board member of Fertility Society of Bangladesh and the ICOG Governing Council member. Welcome, Ramani Madam, to conduct this particular panel. And of course, our co-moderator of this particular panel is none other than Dr. Sneha Bhuyar Madam, about whom we've been listening to throughout this entire webinar. And I don't think I can talk too much about Sneha because she's my friend, philosopher and guide. Coming from a small town like Yavatmal, she has reached great heights in FOGSI thanks to her extreme hard work, sincerity and dedication, her ability to do teamwork, her ability to hold the hands and take everybody forward in the process of improving the health of society. She's been having awarded numerous awards. She has been the founder president Vidarbha ISOPARP. She's president YOGS, Yavatmal OBGYN Society, and of course, the chairperson of our breast committee. So many talks and publications to her credit and so many awards to her credit. Over to you, Dr. Ramani Madam and Dr. Sneha for this wonderful webinar. I just want to let you know that Dr. Chitra is unable to make it. Over to you for the rest of the panel. Thank you.
So by the time I start sharing my screen, yeah. It is indeed a great pleasure to be a moderator for this, one of the very important topics, that is breast concerns and the solution. So with me, I have the Dr. Sneha Bhuyar as my co-moderator, And the panelists are, I think Dr. Chitra is not able to join. Dr. Deepa Mukundan from Trichy, Dr. Marianne from Kanyakumari Nagarkoil Society, Dr. Vaishnavi, Dr. Anita Rajoria, and Dr. Sushila Gupta. So, do you have the CVs?
Yes, ma'am.
Dr. Charu? Yes. Then I should stop sharing now.
Yes.
Okay. Mr. Reddy, please post the CVs.
Yes.
Next, after Dr. Chitra.
Yeah. Anybody is going to introduce, or let me introduce Dr. Deepa. Deepa is from our own Trichy Society. She has been the past president of Trichy OBGYN Society, South Zone Coordinator and Executive Committee member of Midlife Management Committee of FOGSI, EC member of Tamil Nadu Federation of OBGYN. She has undergone training in UK in endoscopy, confirmed certified IMS menopause practitioner, and she is the winner of Champion of FOGSI Award in 2020. And I'm happy to say she has won under her leadership along with the president of Trichy, she has won the President's Rotating Trophy for the year 2021 for the best society, again Lactocon Conference, and then World Environmental Day Awards as Secretary of TRIOX. She has been a faculty in many national and international conferences, and more so, now she is the UNICEF certified trainer for DIRA program, and along with me, we have started doing numerous DIRA programs in Trichy. So, you move on to the next.
Thanks so much for the kind introduction, ma'am. Thank you.
And then the next one is Dr. Mary Ann or Annie Thomas. She has been the past president of Nagarkoil Society, past Rotary Club District 321 president, chairperson of South Zone Women Doctors Wing, and national coordinator in Safe Motherhood Committee, ICOG registered faculty, and then honorary faculty in Sri Mukambika Institute of Medical Sciences, organizing chairperson of NOXCON 2016, 17, 18, Nagarkoil, invited faculty in many national and international conferences, coordinator for Nursing Guild of India 2017 till date, and organized many awareness programs for walkathons, and then so many programs, medical camps, especially for the adolescent committee. And she has been a member of the adolescent committee, endometriosis committee, sexual medicine committee, clinical research committee, public awareness, endocrinology, and safe motherhood. And she has won so many awards: FOGSI Mailan Smriti Award, FOGSI Fem Award, Wonder Foxian Award, Shailaja and Pandit Award, and then Rotary Women's Empowerment Award, BC Roy Award of Tamil Nadu, IMA TNSB, and Best Editor Award, and so many credits to her. And currently she is contesting for the chairperson post from South. I wish her all the best, and I'm very happy to have Mary Ann with us today. And then the next person is Dr. Vaishnavi, from undergraduate from Thanjavur Medical College, my own alma mater, and MS OBGYN from Government RSRM Hospital, Stanley Medical College, senior resident at Sri Muthukumaran Medical College and Research Institute, currently assistant professor in the same college. Welcome to Dr. Vaishnavi. Dr. Sneha, would you please kindly introduce the other two participants? Sneha?
Yeah, I'm here. Dr. Sushila Gupta, she is our own breast committee member, and she is from Delhi. She's a director and senior consultant obs-gynae from GNH Excision Medical College, New Delhi. She's a consultant Fortis, Shalimar Bagh, member of breast committee, as I have already shared with you all, advisor of DGF North, chairperson to breast and cervical awareness screening and prevention committee, and she has many awards and accolades to her credit. Welcome, Dr. Sushila Gupta. Next, please. We have Dr. Anita Rajuria, who is also a breast committee member, and she is a senior consultant from Delhi. She has various affiliations at present, Asia Oceanic Federation of FOGSI, and she has association, or she has association with the Delhi Gynec Forum, NARCHI, IMA, and many other organizations. She's got major achievements. She's the founder, vice president, Delhi Gynec Forum, chairperson, Reproductive Endocrinology Committee, AOGD, and chairperson, Adolescent Health Committee, AOGD. She has had various posts in AOGD, and she has received numerous awards and publications to her credit. So I welcome you, Dr. Anita Rajurian. She's also contesting for the post of chairperson, Medical Disorders Committee. So all the very best and welcome.
Thank you, ma'am. Thank you so much.
Next, have we done?
Yes, ma'am.
Yeah. I'll start sharing my screen.
Yes, ma'am.
Yes. So, the agenda of breast committee is tackling 3 issues. First one is breastfeeding promotion, and then the second one is handling benign breast diseases, creating awareness regarding breast cancer, and then how to detect the breast cancer early. So there are 3 levels of sensitization. First one is sensitizing the FOGSians by organizing academic sessions, publishing e-newsletters, updates, and readiness, and training the paramedics for clinical breast examination and to reach common people regarding the self-breast examination, creating awareness in common people and organizing screening programs for early detection. These are all the aims of the breast committee. So the breast has always been a symbol of womanhood and ultimate fertility. As a result, both the disease and the surgery of breast evoke a fear of mutilation and loss of femininity. So any woman who has got some problem in the breast, immediately she thinks about malignancy and she is very scared. So now coming on to the first case, a 20-year-old girl, she came with complaints of a painless breast in the lump in the right breast since 3 months. On examination, the lump was round, well-circumscribed lump, which was about 2 into 2 centimeters, firm in consistency, non-tender, that is freely mobile and not adherent to the skin or underlying structures. Since Dr. Chitra is not there, Dr. Deepa, would you like to take up this case?
Yes, ma'am. Am I audible?
Yeah. See, what do you think the probable diagnosis could be?
This is a young girl of 20 years. It's a painless lump. It is freely mobile. It is just 2 centimeters in size. Very likely to be a benign, first of all. It could be a solid lesion or it could be a cystic lesion, but then it is very likely to be benign. And the most common entity in this kind of age group is fibroadenomas. So we have to freely mobile, what they call as breast mouse.
Yeah, commonly called as breast mouse, and fibroadenomas are very common in this age group. Does it need further investigation? If you see this particular patient, would you tell her, counsel her that this is enough, this is a benign lesion, or you want to add up some more things, some more investigation to make sure that it is only a benign lesion?
Actually, investigations are not required unless it is growing very fast or there is associated pain or some nipple discharge or anything else that is sparking any suspicion. Otherwise, just reassurance will do. If at all the patient is anxious, we can offer her a simple sonography, mammosonography, which is non-invasive, and we'll have a tissue, a reasonably good diagnosis as well.
Yeah. Then suppose if the patient is, if instead of the mass being 2 centimeters, 2 by 2, if you find on follow-up if the size of the lump is increasing, or when she comes to you itself, it is around 3 into 4 centimeters, would you like to treat this patient?
Some fibroadenomas called giant fibroadenomas, they can grow above 4 centimeter size, and especially the differential diagnosis will be phylloidous tumor, which is again a recurrent entity. So in which case I would like to know what kind of a tumor this is, if it is 4 centimeter or above. So I will go for the next step. Mammography, mammosonography will be my first step, and then mammography can also be done in this patient.
So you mean to say that again, if the same lump is, if the size of the lump is larger, it is always safer to go for a further investigation. So this is the picture. That is, you can see the sonomammography. Ideal is when a woman is around 20 years, safest thing, less than 35 or even 40 years, I would suggest the first line of management imaging modality is only the sonomammogram. Okay, then after this, what is Ncbi guidelines for management of fibroadenomas of the breast?
Small fibroadenomas less than 4 centimeters in a young patient less than 30-35 years with no negative history, like no family history of malignancies, no family, no personal history of risk factors for malignancy, etc. They can be managed conservatively. Small fibroadenomas, we can just reassure them, even if they are multiple, they don't need any treatment. The risk of malignant transformation and growth is very small. So all they need is emotional support and reassurance initially. But if they are really concerned, if it is a big fibroadenoma, like I said, more than 4 to 5 centimeters, when there is a suspicion of phylloidous tumor, or there is a positive family history and the age is above 35 years, 30 or 35 years, then I would go for further investigations like FNAC or true cut biopsy and mammography, obviously.
So, right. So the initial thing will be the reassurance, follow up the patient if it is a small lesion, or otherwise, if there are multiple smaller lesions, what will be your management? Is it going to alter your treatment? Because like benign phylloid tumor and giant phylloid tumors, it's totally a different entity where we need to go for a surgical correction. But on the other hand, if you see small lesions, but they are multiple, what you're going to do?
Again, it will be reassurance, ma'am. If it is not growing, actually multiple lesions, if we do surgery, it will be even more mutilating. So I would like to just give them proper support emotionally, saying it is just reassurance and telling them it is going to be benign. Even if we remove, it can recur. So that is one possibility. So no need to go in for surgery immediately unless there is any other special concern.
Yeah, any other medical management of fibroadenomas, especially the small multiple fibroadenomas, which are not uncommon. Bilateral small multiple adenomas in young girls can happen. Any other medical management? Anybody else?
Ormeloxifene is a option, ma'am. Multiple.
Yes, ormeloxifene. It is given at the
with
dose
pain or associated fibroadenosis, especially.
Yeah, more than fibroadenosis, it's a drug of choice for fibroadenoma also, where 30 milligram on alternate days, it can be given for a period of 3 months. So that has found to reduce the size of these multiple fibroadenomas. And it's a sort of like the patient has also got a feeling that the lesion is getting reduced in size. Okay, now let us move on to the next case. Dr. Charu, Dr. Sneha, can you take up the next case?
Yes, madam.
Or would you like to add up anything to the previous case?
Yes, I think Deepa has covered almost everything. Only thing, what in this particular case, we had the size of 2 by 2 and young girl. So very clear-cut message that, young girl, small fibroadenoma, reassurance and follow, that should be the treatment. But yes, if at all the patient is very, very anxious, and she is, complaining of some discomfort or distress, and she is very keen on excision, you may have to go for excision. That is one. Secondly, as you have rightly pointed out, what are the sizes, what are the high risk fibroadenomas, basically the one which are persisting after 35 years of age, and those who are having atypical features. That's all, I suppose. And what you have to reassure is, you have to just say that it is basically a benign tumor, not even a tumor, it is just a stromal and fibrous, just a hyperplasia of the terminal duct lobular unit, and malignant transformation is very, very rare. So I think that's the way to reassure, and just, yes, not to miss 6 monthly follow-up for that. Thank you so much. So Dr. Deepa has already taken the first case. So we now we go to, I think, Dr. Anita Rajodia. Yeah, I want you to take up this case, and then serially we go. We have this 35-year-old woman who is complaining of pain in both the breasts. Typically, the pain increases just premenstrually, and she's also complaining of lump in breast. But when you examine, you find that there is no well-defined lump. It is just nodularity thickening, that too especially in the upper and outer quadrant, and the breasts are tender. So what do you feel, Anita, is your diagnosis? How do you support your diagnosis? What do you feel the etiology, and how do you go ahead with the management?
So thank you, first of all, Sneha ma'am and Ramani ma'am, for giving us this opportunity. This case, she's 35 years old, and she seems to be having cystic breast disease, what we call as fibroadenosis, because the history is typical, premenstrual and menstrual mastalgia is there. So it is a syndrome of cyclical mastalgia, and because this lesion is due to the changes that have happened in the breast, and they involve all the cystic changes are there. Then there may be some adenosis of the glandular tissue that has grown, and it is associated with some amount of fibrosis also. So she may have these irregular lumpy feeling in the breast, but we have to just counsel her that this is a benign thing and she will not have any problem. And if she is much troubled by pain, then of course she will need some medicine. And if the patient is not convinced, we can have ultrasound also. She's young, because we have to rule out there is any other associated deeper lump. If we are not able to feel on her clinical examination, then of course ultrasound will help. And sometimes if the patient this patient is 35, and if she is more of age, then of course she needs to be investigated for other associated problems. But in this case,
what do you feel is the cause of this this disorder?
This is the growth of the glandular tissue. This is the adenosis.
This is basically because of the imbalance of the hormones.
Yes, it is related to estrogen and progesterone in the younger age group.
Okay.
So we have to give her proper counseling, and we have to take that the risk of malignant transformation is very, very rare. Very rare, and it is less than rather 2 to 3%, they say.
Right.
So we will counsel her, and if she has this cyclical mastalgia, we can give her some painkiller, or as madam has already talked about ormeloxicin, we can give her for 3 months. Then some have used even
any lifestyle modification you want to advise her?
Yes, ma'am. Patient should be advised to have tight breast support. She should restrict caffeine, coffee during that perimenstrual phase when she has that trouble. Then she should have avoidance of these soda drinks. Fat intake should be restricted. They say that even restricting the sugar and salt intake also helps during perimenstrual phase. She should have a lot of fruits and vegetables. Then good breast support, as I've already highlighted. If the pain is much, she can be given some NSAIDs for that. And sometimes evening primrose oil, they have tried fish oil, vitamin E. And if sometimes pain is excessive, we may try a short 3-4 month course of
So first and
also.
foremost, most important is she should stop exogenous estrogen if at all she is taking any combined OC pills. And though there is a paradox, in some cases, in fact, it is relieved by the OC pills. So, but yes, if she is already taking OC pills and she has breast tenseness or tenderness, then we may have to stop it. So she has two aspects to be managed. One is pain and second is lump. So when you examine, you don't find any lump, but when you do ultrasonography, suppose, I think madam will show you in the next slide, you have the ultrasound pictures of multiple cystic fluid-filled spaces. Okay. So suppose if one of the cyst is a little bigger, slightly tense, that is causing pain to her. So if pain is a major concern, would you like to aspirate this?
Yes. If the pain is a major presenting symptom, we may do needle aspiration under ultrasound guidance. Patient will have definitely relief.
Yes,
from
but
it.
provided if she doesn't respond to all this medication. Okay. Okay. So her pain you have taken care of, lifestyle modifications you have done. Suppose her pain is not relieved, you are applying local gel, you are giving her NSAIDs. It is still not relieved. So what else you can give apart from all these empirical medications?
Literature is replete with Denazol and Tamoxifen treatment also in those cases who do not respond to our general supportive management. Then in some of the selected cases, these SERMs, as we have already discussed, ornithopsin
definitely has a place.
But initially they used to give Denazol and Tamoxifen, but Denazol causes a lot of androgenic problems, so it should be better avoided, especially in women.
Correct.
So, Tamoxifen can be tried if no other treatment is helping her.
Correct. So I think very well done, Dr. Anita, and over to Madam Ramani Devi.
Yeah, I think Denazol, the dose in which we give for fibrocystic disease is very, very minimal. That is only 100 milligram. So for a short time of suppose if it is not responding to any other medication, there is a role. And again, I personally feel we have to always have a watch over these patients with fibrocystic disease, because even 3%, 2 to 3% change in malignancy is very, very significant.
In fact, madam, that was the main intention, that suppose if these patients, they are not relieved of by lifestyle modification, breast support, painkillers, and all these medications, then the tense cyst you can aspirate, so it will be diagnostic as well. It will
not only aspiration, we should be sent for cytological examination.
So it will be diagnostic as well as therapeutic.
It has got two components, not only with the adenosis component, but fibrosis component also. So in some situations where it is involving only a local quadrant, maybe even surgical excision in women with a background of high risk for CA breast has to be considered. So that is one point what I wanted to add. Okay, so management, all these things we have discussed. So coming to the case number 3, so it is again para 1, delivered 5 days back. She comes with a history of fever with chills, overfilled, tight breast with shiny nipple, very painful with no milk flowing, red breast, and probable diagnosis. Has Mary Ann come back? Mary?
Yes, ma'am. Yes, ma'am.
Yeah.
Good evening, ma'am.
Good evening to everybody. Discuss this case, Mary.
Okay, ma'am. This is a case of mastitis, breast abscess.
Yeah, could be mastitis or it could be
because she has delivered 5 days back and she has come with fever with chills.
What case madam has described is only at present she has only the enlargement, tenseness. Right now there is no abscess formation.
There is no abscess.
But she has fever with chills, no, ma'am.
Yeah, it could be a yearly mastitis. See, but it could be early mastitis, but we cannot rule out abscess because the breast abscess spreads so fast. It's all because of the loose areal tissue. The day before you would have seen a mastitis, but on the third day, if she comes, you will see a frank abscess. So it is so fast. Okay, you go.
That is why we are going sequentially. So if at all you miss it at this stage, what will happen next. So over to you, ma'am.
Okay. So now what are the probable causes do you think for mass?
Engaged breast, ma'am. Overfilled milk in the breast. And delay in, improper breastfeeding.
Yeah.
And poor attachment to breast, and then that is what the infrequent emptying of the milk, and restricting the hours of feeding also, because we need to feed every 2 hourly and at demand, but many do it maybe 4 hourly, 6 hourly. So in these cases also this happens, ma'am.
Okay, so whenever there is poor latching, when the baby is not completely able to suck or drain the breast, maybe there is some retention of this milk, and this can lead to mastitis. So the first thing we must teach our mothers are the correct latching position. So can you describe about the exact latching position?
We need to hold the baby in the hand with the pillow, preferably with the pillow, and we should sit straight also, not bend so much, and then see that the baby is kept at the level of our hip. So the baby's buttock should rest on the palm of the hand, and the head on the elbow. So with that, if you keep the patient with the baby, we have to keep 2 fingers around the areola and make the baby suck in the proper way, ma'am.
Yeah, the most important thing is the entire nipple should be lying free within the mouth of the baby.
Yes,
and the areola should be caught by the jaws, so that this will again promote the hind milk also getting drained, as well as it will prevent the nipple rashes, the nipple injuries. Like you don't get the sore nipple because the entire nipple is lying free within the mouth of the patient. Okay, so
what we can tell patient is that the lips of the baby should be turned outwards, and the areola should not be visible, especially in upper part.
The whole of the areola should be the baby's mouth. Okay, so we see a lot of patients with flat or inverted nipple. So how can we avoid this, or whether these women will have difficulty in breastfeeding? Dr.
Definitely they
Sushila
have
Gupta?
difficulty.
Yeah, definitely. Dr. Sushila Gupta, can you enlighten on this?
Hey, everybody, and thank you very much for making me part of this wonderful program. And inverted nipple, sometimes if they are anatomically inverted nipples, sometimes they do not give any problem. When baby sucks very vigorously, then milk draw is already there. But sometimes if there is a difficulty in inverted nipple, it can be pulled out by creating some suction, like by applying shield, or breast pump, or there is some before, and we were used to use syringe also, 10 ml syringe to pull the nipple, but it is very painful, and these days we try to avoid that method, because already other methods are there, and we have to give reassurance. If baby is sucking very properly, then there won't be any problem.
Yes.
Anybody see, we now have small like a breast pump like thing, so which can get attached to that instead of that is replacing the syringes, so it can invert the nipples without causing much of pain. So antenatal examination of the patient for inverted nipple is a must, so that we can prevent these complications in the early during the lactation period.
Before delivery.
Yeah. Okay.
During delivery.
So how to manage this breast engagement, Dr. Mary?
So if there is any collection, then we have to expel the milk outside, ma'am, whatever is collected inside, and express the milk. And before feeding also, we have to stimulate the nipple, and then see that the collected milk is expressed out, and then the patient should be very relaxed also. Even a little bit of massaging will be helping her. And after feed also, she can use some cold compress, or cold compress is best for after feed, ma'am.
So, panelists, my one question is, would you like to have a cold compress for the breast engagement or a warm compress?
Warm, usually warm compress.
Cold only, ma'am.
Warm compression before the
Feed.
and cold compression after feeding.
Yes, perfect.
Yeah, cold compressions are always safer than warm compression because warm compression sometimes it will aggravate mastitis. I've seen a lot of these people, see, when we tell them that some form of fermentation, they will give some hard fermentation. They will finally land up with a frank breast abscess. Instead of that, we can tell them to have some cold compress or even use of cabbage. That is a very good thing. So what we, cabbage is a very good thing to express the, that will imbibe that. Again, in South India, we are in the habit of
jasmine
neem leaves and jasmine flowers. Jasmine flowers and neem leaves, we ask the patient to keep below the bra, and then it gets that, they get a very good relief of this breast engagement. Okay, so...
And in this case, ma'am, I must admit that prevention is the best cure. We should... That should be counseled enough that this should not happen because it causes an irreversible cycle.
Correct. So then, how to express the breast milk? I think you have all a gentle massage followed by slow compression, keeping between the thumb and the other finger, and be gentle and patient because if you are going to compress it severely, it is going to cause a severe pain also. So then this is what we have discussed, cold compress versus hot compression. And then now we are very comfortable with all these breast pumps which are available commercially. Okay. Then, so now anybody can share what is the ideal position? I think Deepa has been keeping quiet for some time. You can come out with the breastfeeding positions. What are all the positions you see?
There are multiple breast feeding positions have been described. There are so many positions, but I think the crux of all the postures is the part should be clearly exposed. All the breast should be exposed and loose clothes should be wearing, and position should be as such like baby's mouth and navel should be in one line and head like little above, and all the breast nipple including areola should be in the mouth. Position should be as such as so baby sucks with the areola and the nose touching just touching the breast. There should not be any compression on the nose. If all the positions should be fit in this position. Mostly there are multiple names like Australian lap and football and cross legs, and there are so many names, but ultimately the posture of the baby and mother's approximation of the breast is the same.
So mothers and comfort is the most important. Whatever position she takes,
whichever position she and the baby are
comfortable, that is always advisable. So good breastfeeding techniques are mother should wear I think Dr. Sushila had explained everything. Comfortable dress, and then breast should be very well exposed, properly positioned, and the mouth, chin, umbilicus, everything I think she has dealt. So now let us move on to the case number 4. Dr. Sneha, you can take over the case number 4.
Yes, madam. Yeah. So Dr. Vaishnavi, we come to you now.
Yeah.
You have this patient, 25-year-old para 1. She had just delivered 10 days back. You have already discharged her. One fine night, she comes back to you with, high-grade fever, painful breast lump. When you examine, you find that pulse rate, she's got tachycardia, blood pressure is normal, high-grade fever. Her right breast is engorged and tender. Left is also engorged tender, but on left side, you have a, tense, tender, hot, fluctuating lump of 6x6. What is your diagnosis and how would you manage this case?
Yes, madam. Good evening. We have a para 1 woman who's just delivered just like 10 days ago. So the cause is most likely related to puerperal infection mastitis on one side, that is the engorgement, and there is tenderness diffuse on one side. And on the other side, you mentioned a lump that is fluctuant and the patient is having
Yes,
fever,
left side.
tachycardia. That is most likely pointing towards an abscess. And the mainstay would be to incise and drain the abscess and start the patient
Is it? Do we incise all the time, or do we have some options? And
first, on the side where there is only diffuse mastitis, I would just
no. We talk about breast abscess only.
Can I take
the moment you correct the position, the moment you correct the latch, the rest of the other breast will be taken care of. So we have finished the engorgement part of it. Now this patient has got left-sided breast abscess.
Needle aspiration can also be done, ma'am. Nowadays, we are doing needle aspirations. They can be done multiple times also if it doesn't evacuate in one.
Yes, Dr. Anita, how would you justify your stand? Incision and drainage versus needle aspiration?
Yes, needle aspiration is very good because it is very comfortable for the patient. She doesn't need any admission, and she doesn't need surgery, because the surgery may be bad. It may give scar on her breast. Then mother, when she has undergone surgery, she will be separated from her baby, which will cause further problem in other breasts also. It may cause engorgement. Patient has it has been seen that even despite doing 2 or 3 aspiration, patient has lesser pain than surgery. It has been there have been enough studies that needle aspirations are always better in these patients.
Yes. So just to sum up, what Dr. Anita has said. Pus anywhere in the body has to be drained out. Dr. Vaishnavi, fully agree with you. But the methods of drainage would change here. Now, why this is so? I'm sure all of you must have managed such cases of breast abscess. In olden days, we used to refer the patients to surgeon, and they used to undergo incision and drainage. And the patient used to come back to you, maybe, or to the surgeons, daily dressings and packings. So it was such a messy thing to do the daily dressings, and it was such a painful thing for the patients to, undergo that dressing. Because of this, she has to stop breastfeeding on that side. Because of pain, she was not able to, breastfeed the baby. So the things would worsen, the situation would worsen. But now we have this option of needle aspiration, where you can, directly put in a white case needle, maybe number 14 or so, and then you can just aspirate. If the abscess is small, even single sitting would help the patient. Of course, your antibiotics, anti-inflammatory, hot fermentation, everything. And on top of that, correction of the good latch and good breastfeeding techniques regularly would solve your problem. But in this case, because it is a 6 by 6 centimeter, a larger abscess, you have to, put the patient for repeated needle aspirations. Now, because it is, very superficial aspiration, you don't even need ultrasonography. But because breast abscess usually has multiple loculi, you may have to, break the loculi with this needle, and you may have to, pierce the abscess from different sides every time. So maybe few sittings of aspiration along with all your specific and supportive treatment should, take care of this patient. So that's the very reason. Madam has already, projected this slide saying that Cochrane database says there are at least 6 studies which are around 300 cases, quite sufficient. And we have our own members, including me. We are, regularly doing this needle aspiration. We are having wonderful results. One of our member who is a lactation consultant, international board certified lactation consultant, Dr. Mangalavani, who has more than 150 cases to her credit, and she is practicing in Pune as lactation consultant. And over last 5 years, she has not done any of the incision and drainage for any patients. So majority of the obstetricians are also referring the patients to her. So we have enough data to support this. Our aim is continuation of breastfeeding, because all of you will agree it is so beneficial to the mother as well as the baby. So I think our aim should be to continue breastfeeding and not to abandon breastfeeding. I think that should be all for this case. Thank you.
Regarding the use of antibiotics, if you are going to do a repeated aspiration in a sterile condition, there is no need for antibiotics according to
Yes,
proper evidence.
it is only for the initial abscess, which what infection it is already, there. So it is to take care of. When we are doing it, madam has absolutely pointed right that when you are doing it under aseptic precautions, then definitely she will not need additional antibiotics. Very true.
Yeah, she can also continue to breastfeed from that side also. So if the patient is subjected to IND, most often the dressing part of it and the drainage of the pus and the drainage of the blood, the baby will not like the smell also. So it will not start, it will not last the breast itself. So probably that all these things can be avoided by simple needle aspiration. So can a mother with the breast abscess breastfeed? So this is what we have already discussed.
Yes, already.
No need to stop the breastfeeding. So then, now coming to the next part of it, the last part of our agenda, that is about how to go about for breast cancer screening. And this is one thing is risk screening in patients who are at a risk of developing breast cancer, or routine breast screening, and then genetic screening. So why to screen the breast cancer? Breast cancers are found during screening examinations are more likely to be very small, and still they are confined to the breast at early stage. And the size of the breast cancer and how far it is spread are important factors in predicting the prognosis. So cancer, that is screening for breast cancer by self-examination as well as by clinical examination is mandatory. And Dr. Sampath has already clearly explained when to do it and how to do it. So now, can anybody share what are the risk factors? Who are the people who are at high risk of developing cancer breast?
So, elderly people.
Yeah, we have been continuously seeing increasing incidence of breast cancer, especially in urban population and metro cities. So we need that every woman is at risk. We should screen each and every woman ideally, but a woman who is elderly, who has had history of breast cancer in her immediate relatives, or she has personal history in the past, or history of irradiation is there in the past, she has had early menarche, late menopause, or she hasn't breastfed her baby properly, or she has breastfed for a very small time, then these women, they are at risk to develop breast cancer at a later stage. And if a woman is carrying BRCA1 or BRCA2 mutation, for some reason it was done, and if she has that, then she has to be on a regular and close monitoring for development of breast cancer. Then previous history of breast cancer, as I had discussed, because the contralateral breast may also develop breast cancer. Obesity, alcohol, smoking, all these things, history of hormonal intake in the past. So these taking of menopausal hormonal therapy. This is very, very important that we should examine the breast properly before starting HRT in any women. So all these things predispose of women for development of breast cancer. No, it's not that all will develop, but definitely they have to be put under screening and closer monitoring.
So as breast tissue has come under the purview of the gynecologist, I think it is the business of each gynecologist to have a look at the breast and the cervix, which are the very common sites of malignancy. Here I would like to share one of my patients' history. Grandmother had CA breast, mother had CA breast, and both of them are treated and okay. And the third generation, the girl came to me for infertility treatment. Clinical examination was perfectly normal. She was treated with ovulation induction with IUI, and she conceived and she delivered. Then after delivery, she went back to her mother's house at Sri Lanka. Then after a week's time, she gave me a frantic call. Madam, I saw some swelling in the breast, which I am worried. Then she wanted to come back to Trichy because Trichy and Sri Lanka, Colombo are very close by. It takes just hardly 45 minutes. So when she came on examination, she was also found to have CA breast in a lactating breast. So that when these patients, like when these 3 people were subjected for BRCA1 and BRCA2 mutation, they were found to be positive. So fortunately, this girl had a male baby. But still, I would say, even in a male breast, the chances of getting CA breast is quite high in such situations. So self-examination of breast, I think that we have, Dr. Sampath had extensively dealt with it. Anybody wants to add anything else? Dr. Vaishnavi, you have been keeping quiet. Vaishnavi? She's not there.
Yeah, can I take that, Ramni ma'am?
Yes, ma'am, I'm here.
Patient should.
Sushila, are you here?
Vaishnavi is there. Yeah. Yeah, Vaishnavi?
Self-breast examination is also very, very important, because the first person, because she knows the size, shape and texture of her breast. So if she is intelligent enough, she will be the first person to notice if there is any change. And is similarly to the clinical examination. And this examination can be done in a circular manner to cover complete breast and plus angle also.
And self-examination has to be carried out ideally in.
Should be examined and in the circular manner or radiating manner. Both can be done, and the third in the parallel manner also it can be done. I want to ask one question. There was distribution of the breast scan light. Is there any benefit of that breast light scan? Because I never found any benefit of that. I am having that breast scan light. If you make the dark room and put that light on the breast, it just illuminate inside of the breast. So sometimes it is visible, but we cannot say most of the time it misses all the elements in the breast.
Yeah. Deeper lesions we can miss it, as well as fibrotic breast tissue and bumpy breast. We will not be able to make it out. Only in an average size breast where the fibrotic elements are low and only in certain conditions it may be of use.
It's a thermography actually.
Yeah, thermography.
Yes.
And I think as per the guidelines, thermography should not be done. It should not be done. Better to go for sonomammogram.
Ideally, the patient should be examined in all the positions: standing, sitting, and lying down.
It is like something is better than nothing. Just to add, any gadget to your clinical examination. That's all. We have also used it, more than 500 patients. But yes, definitely for few patients, you can, make out some suspicious lesions whom you can definitely insist on subjecting them to mammography. So I think that's all, if at all, any advantage over that.
Few patients I saw only very vascular breast.
Okay.
So in those cases, we could diagnose, like just because of high vascularity, I subjected to mammography or ultrasound further investigation, and she was positive.
Correct. That is what.
Okay, then anybody can discuss about the signs and symptoms of malignancy. Mary, would you like to take up this question?
Yes, ma'am. Actually, sometimes many a times I have seen patients very silent. It comes and then after suddenly it props out when even a small fibroadenoma turns out to be. They come with a small lesion in the breast and suddenly they come with a real cancer breast, and many a time this has happened, ma'am. So what I feel is like we have to do an FNAC for any patient who comes with a mass in the breast, whatever be it is. And we should also do a mammography, which clinches the diagnosis almost to a certain extent. So these are the two things. And signs and symptoms, of course, we know that there is not much pain, and patient has the usual signs of cancerous lesions. Every patient becomes emaciated, no appetite, and some discharge
Dr.
from
Mary,
the nipple.
you have just listened to the
discharge. from the
Dr.
nipple.
Mary, I would like to interrupt you here. You have just listened to the talk by Dr. Sampath ma'am.
Can I add, Neha ma'am?
Yeah, let me just talk to
little
her.
changes. That is why a woman should be aware of about her breast. That is the importance. If the woman is self-aware about her breast, the consistency, the size and shape, she will notice sudden increase in size or change in shape. These may be, simple symptoms which will carry her to the clinician. So we should give relevance to her history that there is an
self-breast examination. So Dr. Anita, we are talking about the clinical breast examination here, as Dr. Mary is talking about. So with triple algorithm, what we were talking about, the history and clinical examination and imaging and tissue diagnosis. So for tissue diagnosis, what gazette or other, what would be your modality of choice, whether it would be FNSC or core biopsy?
Nowadays,
for Dr. Mary. Wait, Anita, I'll come back to you. Yes.
Ma'am, actually,
This has to spread. Yes. Please let us know.
Easier, cost-effective method, ma'am. Core biopsy is little more complicated, and the patient has to take the full steps to undergo that. Whereas this is
but suppose your patient, because you are suspecting a malignancy, you have to have a definitive tissue diagnosis. And you know what the problems with FNSC, many of the times, it just comes as blood stain fluid, inconclusive, sample not sufficient, few cells can't comment. So likewise, so you have to see the cost and efficacy. Agreed. But where you want to definitely, so here efficacy is in question, right? So when you want to be sure about the diagnosis, I think tissue biopsy or core biopsy or true cut biopsy is to be preferred. Yes, Anita, you would like to add something?
Yes, ma'am. In this triple diagnosis, before the histopathological diagnosis comes the role of ultrasound mammography or X-ray mammography, and if even X-ray is not confirmatory, you are not able to go to any diagnosis. Even MRI may be called for in certain, especially with dense breasts. We may need.
No, we don't recommend MRI. Only
if your diagnosis is not clear, then only we go for MRI of the breast.
So for screening, mainly, as Madam has already said, it is the risk screening, that whether she has any risk factors. Then it is the breast screening, that means whether she has any symptoms or signs in the breast when you examine her, or by her symptoms, that is self-breast, whatever she has noticed, and then signs when you examine without any gazettes. Then of course comes the imaging. So below 40, you prefer to go for sonography. Above 40, you recommend mammography. That too, when you have the dense breast, definitely, the ultrasonography is more helpful. And in this scenario, sonomammography, you have to club both the things for optimum results. Okay. And mammography, as you have said, Dr. Anita, it is, in a high-risk woman. Breast malignancy is the only malignancy where you have high risk and average risk. You don't have low risk, because 1 out of 8 women has a lifetime risk of having malignancy. So it is high risk and average risk. So for average risk, whatever we have said it till now, and for high risk, it is the 6 monthly mammography and MRI, or annual mammography and MRI. So that is how you have to define how you should screen these women.
And then one most important thing is, always after you find a clinically a mass, subject for imaging, don't be in a hurry to do FNAC. Because by doing FNAC, sometimes there may be bleeding, and if you subject the patient for mammography, after that there will be alteration in the classification. Go step by step.
Yes.
First,
and that is why the triple algorithm.
Yeah, that we have to follow. In Virat's category 1 to 0 to 6, Dr. Sampath had very clearly explained, and there are of course certain limitations of the breast ultrasound, because for a larger breast and a fibrotic breast, it may be difficult to do a simple sonomammography. So in such cases, if the patient is less than 40 years and if you are very inconclusive about the findings of sonomammography, then there is a place for breast MRI. Okay. So then regarding the biopsy, I think it has been again discussed, FNAC versus true cut biopsy versus in conditions where it is going to be a very small lesion and suspicious. Sometimes even by FNAC or true cut biopsy, you don't get a proper tissue, then we are justified doing a lumpectomy. Excision biopsy may be done, but always see to that when you are doing an excision biopsy, suppose if the report comes as malignancy, you should take in the subsequent incision, that scar should come out. That's one important thing. Understand? Suppose if you are going to do a radical surgery, modified radical mastectomy, subsequently in the event the lesion turns out to be malignant, the incision what you have put for lumpectomy should be within that scar. Otherwise, it will cause some unnecessary, some cosmetic abnormal cosmesis can happen. So these are all the Dr. Sneha, would you like to explain this breast cancer screening guideline?
Yes. There are many organizations, including the United States Preventive Services Task Force, American Cancer Society, American College of Obstetricians and Gynecology, American College of Physicians, and American Association of Family Physicians. More or less, they are almost similar. All of them unanimously, they agree to it that there's no need for screening before 40 years of age for an average risk woman. For an average risk woman, we have already said for a high risk woman, it should be 30 years and above, or maybe if the woman who has family history of breast cancer, at least 5 years prior to the age of her relative who has suffered or has been diagnosed to have breast malignancy. So that is how you have to, subject them for this screening. But for an average risk woman, all these organizations, they recommend that there is no need for screening before 40 years. Just one second.
So this is what you have mentioned for high risk and low risk. And then coming on to the case number 5, a 32-year-old nulliparous woman noticed a lump in the left breast a month ago. It was painless. On examination, it was a vague lump of 2 to 2 centimeters with an irregular outline, non-tender, hard in consistency, without any nipple discharge, axillary nodes, and right breast was normal. So what do you think the probable diagnosis, Dr. Sushila?
As the lump is of the short duration and irregular outline, hard in consistency, seems to be malignancy.
Yeah. So then the next step is, once when you clinically suspect malignancy, how you are going to proceed?
Complete clinical examination.
What we have discussed earlier.
We have discussed triple test, complete clinical examination, imaging, and histopathology. And histopathology, whatever we have discussed, true cut or core biopsy has to be checked. And not only for biopsy, we have to do hormone receptors also, ER, PR, and HERS also, so that further we can plan the treatment. And while diagnosis, we have to look into the receptors sensitivity, ER, PR, or HERS, plus staging of the patient. So further chemotherapy or hormone therapy or immunotherapy can be decided. Or if its staging is like more or forward, then new adjuvant therapy can be planned. Also,
I think this comes under the purview of the oncologist. So as far as we are helpful in diagnosing the malignancy, beyond this, it should be handed over to the oncologist or rather a team of oncologists who they have this onco team. Chemo, radiotherapists and surgical team should take over this patient and then they should do the needful. Okay.
Can I just add a point here, ma'am?
Tumor board should come to a place here. Tumor board role is very, very important.
Yeah, actually, as Dr. Sneha ma'am said, FNAC is being phased out. It is now the true cut and core biopsy. We can also do receptor studies if we have a good chunk of tissue. So in breast conservation surgery, which is now picking up, a lot of people prefer to do true cut biopsy and core biopsy. That gives not only histological diagnosis, we can also do receptor studies in those patients, and we can actually modify the treatment which can be suitable for that patient. So I think we get a lot of information from core biopsy rather than just FNAC. I think, and then we can proceed to counsel the patient, because we are seeing breast cancer even in young patients nowadays. So breast conservation surgery is definitely an option. So that is a way to go. After that, we can hand over the patient to.
So again, like Deepa, how Deepa has said, with the advent of this receptor study, probably before jumping into surgical modality of treatment, we can give chemotherapy, reduce the size of the mass, and then go for conservative breast therapy. Yes. Then oncoplasty can be planned along.
Can I step in, Ramani, madam?
Yeah, sure, Neha.
Yeah. Definitely, madam, as you have said that, and what our committee is also promoting, that early diagnosis. And because we want to diagnose this patient as early breast cancer, so that the prognosis is very good as far as her long-term survival, 5-year survival, and tumor-free or cancer-free survival is concerned. But because Dr. Deepa has very rightly pointed out, because we are getting younger and younger women, for breast cancer, our job is not yet over, because we have to take care of their obstetric career. So before we hand over this, or even after we hand over this patient to the oncosurgeon, we have to keep continuing follow-up, because, we have to decide her obstetric career. So before we start any of her treatment, including chemotherapy, we have to see and discuss, bring in the ART team into picture, consult with them, and then counsel the patient and the relatives, and whether they are willing for cryopreservation of their gametes. That is one.
Cryopreservation should be discussed with all these women.
Yes.
And again, not that every woman with breast cancer, they need ART. See, you can always see in young patients not having a very aggressive sort of chemotherapy, they do regain their ovulation status.
Yes, but madam, sometimes it can be temporary or permanent. Yes.
So
we have to be on the safer side. We have to just discuss and leave the decision to them. Yes, leave the decision to them. That is one. Secondly, we have to take care of their management and see when they complete. We have to advise them when they can conceive later on also. And we have to see when during these treatments, she is not supposed to conceive. So what contraception she should use, that also we have to take care of. So that's the very reason I have just said that our job is not yet over just by referring the patient, though the oncological aspect is to be taken care by the oncosurgeon. Thank you, madam.
Okay. So then coming to case 6, you take over this case 6.
Yeah. I think, we don't have Dr. Chitra here, right? So, whom should I, Dr.
Vaishnavi.
Yes, is she there?
Is not there. Yeah, Vaishnavi.
Yeah. So, Dr. Vaishnavi?
Unmute yourself, Vaishnavi. Yeah.
Is she there?
She's there.
But she's not. I don't think she can.
You go pass on the question.
So I think once again I will ask this question to Dr. Deepa. Deepa, you have this 25-year-old para-1 who has just delivered, 2 months back, and now she comes back to you with some pain in her right breast. When you examine, you find the breast is, swollen, tender, edematous. A little powder orange appearance near the nipple areola complex. Nipple is slightly retracted. There's no localized lump here, but she, typically she tells you that she's got an insect bite like itching. And you, on further inquiry, you find that she has already received antibiotics, anti-inflammatory since last 2 weeks, but there is no improvement. what do you feel your diagnosis is? Whether I would like to ask you, what is your differential diagnosis and how would you go ahead with the management?
Especially this is a lactating woman and she has some vague signs of inflammation, but it just there is no lump. So, and especially this orange peel appearance is actually worrying to me because that is very typical of malignancy. And in this patient, because we don't have any lump,
subacute edema. When you have the subcutaneous edema and maybe a little lymphangitis there, you can have this picture. Yes. But the very fact that she has received antibiotics and anti-inflammatory,
there is no response.
Yes, improved.
Yes.
Right.
So that is a clue. She's not responded to antibiotics, and there is no actually progression to an abscess also. So I'm now thinking in terms of possible lactational carcinoma or something which has to be ruled out. And because I can straight away subject her to some kind of imaging now. Maybe here MRI would be a better option because it's a diffuse thing, and you want to know about the underlying lymphatics nodes as well as the architecture of the breast. So this is a patient whom I would subject maybe first to a mammography, of course, and then if necessary an MRI straight away.
Yes. Very well said, Dr. Deepa, because this is a patient where here the malignancy may not be even diagnosed on mammography. It is not even diagnosed on mammography. Even sometimes MRI can miss it, but the confirmatory diagnosis is, of course, tissue biopsy only. So MRI is likely to pick up this case, but still for confirmation, you have to go for tissue diagnosis, that is histopathology. So now suppose she's a young girl and young lady rather. So how would you go ahead? What do you know about this malignancy? How would you counsel the relatives? What kind of malignancy is this? What would be the likely treatment?
This is actually a very fast progressing malignancy. It is a very aggressive type. It can metastasize very early. It has a poor prognosis, and so the patient has to be started on treatment ASAP immediately.
Yes.
That gives a survival benefit for this patient. Definitely.
Yes, and just to bring it to your notice that the very fact that it has reached the skin, it's already stage 3 and beyond. So it is aggressive. That is one. It happens in younger age group, but basically the diagnosis is too late when already it is in an advanced stage. Then the diagnosis. So difficulty in management, and of course the 5-year survival is very poor. Right.
Recurrence rates are also very high. They say recurrence is also very high.
Yes.
Local. Yes.
So then again,
they may come late also.
Yeah, most important thing histopathologically is there is obstruction of the lymphatics by malignant cells. That is pathognomic of this inflammatory carcinomatosa of the breast.
And so the skin biopsy.
Yeah, skin biopsy is very, very important rather than that skin biopsy shows the lymphatics are obstructed by the malignant cells. Okay.
Correct. So I think we are almost here at the end.
Again, this is like any other breast malignancy mammography, breast ultrasound, MRI, and again biopsy and further management we have explained. So the next question is whether we can breastfeed after cancer treatment.
Yes, Dr. Vaishnavi.
Yes, ma'am. Actually, I'm unable to. I was present and I was unable to unmute myself.
Okay. You go ahead, Vaishnavi.
Yes, madam. Actually, they can still continue to breastfeed. Like whatever breast tissue is left. Like if the one breast is still left and she's just given birth to a baby, she can still continue to breastfeed. And there is no option like we need not do that or anything like that.
So would you like to give any contraception to the breast cancer survivors?
Yes. Because they are likely to conceive. Their fertility returns as soon as they stop their chemo or radio. But they should be advised contraception at least for 2 years, as Sneha ma'am has already discussed. And the ideal contraception in these breast cancer survivors will be LNG IOS. It is so readily available, and it is a preferred. And if she is lactational, she can be offered progesterone only pills also, because if she's feeding from the other breast, then she can be put on progesterone only pills also.
Yeah, initially LNG IUS was introduced only for this purpose. Then only from this it has expanded to the all the other methods, like as a contraceptive agent or for AUB, etc., etc.
There was some concern then regarding this also, but we understand that the progesterone release from LNGIS is so little that it won't affect, because sometimes there is concern in PR positive patients.
So progesterone may be a reason for CA breast, but that doesn't happen in this progesterone only IUS, because it will be locally active, and it is able to suppress the endometrial hyperplasia that happens secondary to tamoxifen usage. So how long do you wait for the next for the lady to plan the subsequent pregnancy?
2 years at least after.
Minimum 2 to 3 years. Better you get the clearance from the oncosurgeon that she is fit to undergo the next pregnancy. Okay, then suppose she comes to you with she wants to plan pregnancy. She is in an emergency thing. So what sort of ovulation induction drugs would you like to give?
Letrozole is the preferred choice, because we do not want estrogen levels to be very high. So if at all she needs infertility treatment, we will give a dose which will not cause hyper estrogen levels in the blood. So letrozole would be a good choice for ovulation induction in this patient.
What about ART?
ART can be offered if, as ma'am has already highlighted, if she was elderly and she had cryopreserved her gametes or embryo cryopreservation was done, then of course ART should be, this has to be counseled pre-treatment. Everything has to be discussed with patient and her husband.
Stimulation protocols can be followed for ART.
The only concern is the hormones, what you need to give, extra. So that is a worry.
Yeah, that is why I'm telling minimal stimulation.
Minimal stimulation.
Yeah, where there is no supraphysiological levels of estrogen are expected. Okay. So I think
this is the last slide, which we always talk to all our FOGSians at the end of our session, that every obstetrician and gynecologist has the window of opportunity, because the women come to you for whatever their problems. They are very comfortable with the obstetrician and gynecologist rather than the surgeons. So not only for breast problems, but for any of their problems, they come to you. And that's the very reason you have to utilize this window of opportunity and examine the breast of each and every woman who comes to you. If at all she has any abnormality, you notify and subject her for further investigation. If there are no abnormality, you just teach her self-breast examination, how and when it is to be done. It has to be done every monthly, immediately after the menses, that the week following the menses, and how you should be doing it. That has to be taught to her, so that if at all you notice any abnormality, you have to report to your doctor, so that we can pick up the malignancy early. If not, at least we make her aware of her breast, so that she can keep a watch on whatever abnormal happening to her, and she notifies and undergoes further investigation. So I think we'll be able to pick up the malignancy early, as there is no role of prevention here in breast malignancy, because we don't have any vaccination or any preventive measures for that matter till date. So we are the saviors, because if we detect this malignancy early, we can save her life, we can save her breast as well, and we can save even her obstetric career as well. So that's the very reason we all are savior, and I would urge once again to utilize this window of opportunity to examine the breast of women who are coming to you. Thank you so much, and over to you,
ma'am. Can I add one thing?
Yeah.
A very good carry home message is screening the first and second degree relative of cancer breast patients.
Yeah, I think if we keep on giving messages, we will have many, because what we have said in the history itself, that we are supposed to ask not only menstrual and obstetric history, but we are supposed to ask the medical and family, which actually is a part of a routine examination of history taking. So we must ask for the family history of not only breast malignancy, any malignancy for that matter. So I think a very good point noted by you, Dr. Anita.
One last word is that, Sneka, each gynecologist should undergo screening procedures for pregnancy as well as metabolic syndrome and so many things, which we are neglecting. We have to.
I think
100% true, madam. 100% true.
Yes. In fact, madam, to share with all of you, I have, suggested this survey to the next incoming chairperson for breast committee, that, we have to conduct the survey for all the obstetrician gynecologists, FOGSians. Locally, we have done it for all our doctors, women doctors. Yes. Locally, over last 2 years, we have done it for all our doctors. Yes. The pap smear, mammography, and the routine screening for that matter. So I suggest this to the incoming chairperson that whatever we have done, she has to take ahead this work, and we FOGSians should have our own data that how much careful we are for our own health, and how many of the gynecologists they are screening themselves first and then advising the patients.
I had two of my friends, one gynecologist come MS general surgeon. She diagnosed CA breast only at stage 3 and she passed away within 6 months. Really a pitiable thing. So all these things make me feel that all of us,
the irony of the situation,
we take things for granted and we move away. That is the problem.
Okay, Dr. Anjali here, there was one anesthetist, very senior anesthetist. When she was giving anesthesia for a person with a CA breast, she was just telling how they have missed such a big lump and all. Within next 4 days, she was diagnosed with a breast lump and stage 4. And she succumbed in 10 days time. She has written a note saying that don't resuscitate me if I develop any cardiac arrest or a respiratory arrest. So they have just left her. So such a senior person, she was working in a private college, an anesthetist, died within the diagnosis of 1 week time actually.
So ultimately,
some trigger must be there, like chairperson of the breast committee, some trigger to make everyone undergo screening. Okay.
Yes, that is what for the FOGSians, if you remember, over last 3 years since I have taken up every CME, we have this last slide, and I have been urging all the FOGSians. I am guiding my breast committee members as well that all of them should put this slide as a last slide and talk to all the gynecologists. At least you get screened yourself first, and then you advise your patients. So
we are in IMS, we have just started screening base circumference for all our gynecologists.
Madam, one more important thing is for all malignancy, the base is obesity and diabetes. Consuming sugars, that also increases the inflammatory status and that predisposes any type of malignancy. 100% we know breast cancer is not preventable, but it is only detectable at a very early stage. So as you all have mentioned that let us start this from home. I know my own sister-in-law, I lost because of CA breast. She herself was a ophthalmologist and she was detected to have CA breast only at stage 2B. Unfortunately, she died after 10 years duration. And most important thing is the background was a fibrocystic disease. That is why I keep on telling, I have seen 5 of my own patients having fibroadenosis breast, which was diagnosed outside, but subsequently they landed with CA breast. So we have to give much importance to the patient suffering from fibrocystic disease. Take the background risk factor keep them following more frequently than the routine follow-up what we are supposed to do.
Early, timely treatment gives 10% cure in breast disease, breast cancer.
100%.
Okay, I think with this,
fantastic.
What a nice panel
discussion.
Wonderful panel, and
thanks to all the panelists. They have done a very
thanks
good
to
work.
Ramani madam, thanks to Sneha Buyar madam. I have heard Dr. Sneha speak time and again, but with pep up and top up of Ramani Devi madam's inputs, it has become an even more glowing presentation. And we are really so thankful to have been associated with TNFOG for this particular program. So I think that no program can be complete without a small vote of thanks. And although everybody are family, everybody are friends, but still it is mandatory. And so I think I will do the needful for this particular program. Let me start off with thanking Dr. P.K. Shah sir, who could not join us, unfortunately, Dr. Hirimat sir, for kindly consenting to be our chief guest for today's webinar. Dr. Lakshmi ma'am and Dr. Revati Jankiram ma'am, it was a pleasure knowing you all in a small way. Hope to get to you all know even much more. Thank you for sparing your valuable time here as being as the guest of honor for today's program. And thank you for your wonderful inputs for each and every talk and lecture. Thank you, Dr. Sampath Kumari madam, whom I pestered quite often. She was very busy, but still she consented for this particular webinar. Ramani Devi madam was a big help as always, as whether it was for our FOGSI e-newsletters or whether it was for this program, she has been a saving grace as always. Sneha is family. I cannot keep thanking her, but thank you from the bottom of my heart for giving me this opportunity once again. Our esteemed faculties, our esteemed speakers, our esteemed panelists, thank you so much for sparing your valuable time and being here. Last but not the least, Emcure Pharma. I think I troubled you all also a lot, but thank you for being partners in this particular webinar, and thank you for giving us the Zoom platform and for hosting this. Thank you very much.
Sneha, thank you, Lord, and all the best for all the contestants. Sneha, please support our Dr. Annie and Dr. Chitra. Anita is here.
Dr. Anita Rajoria.
Thank you, ma'am. Thank you so much.
Thank you. Please, all the best for the contestants.
And thank you, Dr. Charu Bapai, Dr. Anita Rajoria, Dr. Marian, and Dr. Chitra.
Thank you very much.
Excellent program, Charlata and the another person. Sorry, I couldn't get the name.
It's okay.
It's excellent. It was an excellent program. Congrats to both of you.
Yeah, thank you so much, madam. This is Dr. Sneha Buyar, chairperson FOGSI
Madam,
Breast Committee.
Sneha Buyar is the heroine of this program. How can you forget her name?
No, I'm so sorry. In fact, I forgot madam's name. And I'm very happy to know you, madam, and hope to be in touch with you in future as well.
Okay.
Need your blessings always.
All the best for everyone. Thank you.
Thank you,
Thank
everyone.
you so much. Wonderful program, and best wishes to all the contestants. And of course, Sneha ma'am and Ramani ma'am, always a pleasure to listen to your panels. Sampath ma'am, as usual, always very clear and lovely talks. Of course, today's program was fabulous. Thank you for having me here.
Thank you, Dr.
Every time we learn something new, Sneha ma'am, thank you for involving all of us. Thank you so much.
My pleasure, dear.
Sheila,
Thank you. Thank you all.
Thank you, everybody. Thank you very much. Thank you for your time. Thank you.
Thank
Good
you,
night.
Dr. Sushila.
Bye.
Dr. Anita. Bye-bye.
Thanks, Charu. That was fantastic.
Thank you, Deepa, for joining. You added so much ronak to the entire discussion. Thank you.
No. Absolutely.
Thank you very much, ma'am. Sampath ma'am, Ramani ma'am, Sneha ma'am, and everybody here. And it was really very good, very nice academics, and really should thank everybody for giving us this opportunity to be